Métis peoples located in Treaty 6 and North Saskatchewan River territory of the Otipemisiwak, or Métis Nation of Alberta. I encourage you all to reflect on the lands on which you are joining today. It's my great pleasure to introduce you to Dr. Kim Simmonds. Kim is the Chief Executive Officer of Primary Care Alberta, a role she assumed in November 2024 as the inaugural leader of Alberta's provincial primary care agency. An epidemiologist by training, woot woot, she brings experience across academia, government, and the private sector. Kim has served as Assistant Deputy Minister of Health and held senior leadership roles focused on health system planning, performance, quality, and innovation, and previously worked as an epidemiologist with Alberta Health Services and a senior leader with Ernst & Young. She holds a PhD and MSc in epidemiology from the University of Calgary. And if that all wasn't impressive enough, if you allow me a moment to editorialize a moment, I'll add that somehow, with all of that, Kim has the time to bake cookies, run ridiculously long distances, be an amazing mom, and look after other people's kids. So she's also a fabulous speaker, and we're in for a treat. So hopefully there's questions, please, throughout the talk. If you have them, feel free to put them into the chat or save them until the end, and we can address them then. So with that, I'll turn it over to Kim. Thanks very much.
Thank you, Amy, for that. I do bake the stress away. And so you know how bad things are at work by the amount of baking that arrives in the office. So let's see if I can do this properly. Hopefully the screen sharing is working. Someone yell at me if it's not, and you're just looking at other work that's showing up on my screen.
You're great. It looks good.
Thank goodness, because no one wants to look at briefing notes that are being reviewed. Okay. Please feel free to ask questions in the chat, raise your hand. I don't know how to moderate that, but I will do my best. I do have a short presentation and then lots of time for questions or comments from people as we kind of refocus things and look at a primary care and population public health perspective for health. So, those of you who don't know, and this is probably for people like Mike Law who moved here, there is a refocused health system. Don't be alarmed. It does look scary, but there are now 4 ministries that are responsible for some component of health. Primary care sits under primary and preventative health services. There's acute care that sits under hospital and surgical health services. Recovery Alberta, which sits under mental health and addiction, and then Assisted Living Alberta, which sits under assisted living and social services. And essentially, there is a government layer, there's an agency layer, and there's actually a Provincial Health Agencies Act that kind of legislates what we're doing and our roles, including our mandate. And then underneath that is the basically healthcare providers. So in Primary Care Alberta, we have a joint venture partnership with Primary Care Networks, but we also have nurse practitioners, public health, and other providers. This is expected to evolve over time, but this is sort of the current state right now. So, Primary Care Alberta, we just developed a mission and a vision and a values, which was really exciting. It brought together public health and primary care, who both do complementary and sometimes even similar roles, but to bring some common language and understanding. So this was really exciting. So our vision is care for you and health for all, and then allowing Albertans to live their healthiest lives, and then partnering with other groups and preventing and reducing illness and injury to help people be able to navigate through the system. So, primary care being the foundation of the health system, and then really having those connections into social and community services. So, we won't go through this. I think it's just important to know kind of the components of Alberta Health Services or other parts of the system that have come over to primary care, because primary care has only been around since February 1st, 2025. So we're just over a year old. With that, we are super lucky to take a whole bunch of the core public health programs that are near and dear to my heart. Communicable disease, public health clinics where you get to snuggle babies, give them vaccines, and do screening, population-based screening as well, chronic disease management, team-based care, and then health promotion and prevention programs, so offering information for schools and others. One of the things that we do that comes from primary care is that health system navigation. So 811, helping people understand how to move through the system, that sort of digital front door and physical front door for primary care providers, including how people will get referrals and move into higher acuity care and then back. We also have the Indigenous Wellness Group. So you'll be familiar with them maybe at HS as the Indigenous Wellness Corps. And that group has come over with us, and we're extremely grateful because, as Amy kind of talked about in the land acknowledgement, is we live on this land, and care is expected to be delivered in the community. And so, while they do support culturally appropriate care across the system, the most important thing is that you feel safe and secure getting good primary care in the local or nearest community in which you live. So those are kind of the big buckets. We're happy to chat through them in a bit more, but I just thought I would let you know kind of that's who came to us. And then our big five goals, which, were pretty much motherhood and apple pie, but I think they're important to highlight access and attachment. So making sure you can see a care provider in your community, that you don't have to go to Emerge or other places to seek care, and that you have a care provider that knows you and is providing longitudinal, comprehensive family medicine care. That there is integration across the system, and the idea that people go out for higher acuity care and then they come back to their medical home or their health home, and that that's really important to us, that everything we do is anchored in that quality, in that quadruple aim, that we're using evidence-informed decision making, and that we are providing that high quality, safe care. Albertans as Partners is such a great one because it's really talking about making sure we have the right information in people's hands, that people know when and where to go and how they can make informed health decisions for themselves. And that's where things like the digital front door and other things come into play. And then last but not least is culturally safe and appropriate care. And I can't highlight enough that this doesn't just mean for Indigenous populations or for patients. It actually means for our care providers to feel safe when they're delivering care. And then no matter who you are or how you look or how you represent, that you feel safe and able to deliver and receive care. So that's kind of what we've done, or us. Year one, we've done some pretty cool things for an organization that didn't really exist more than 18 months ago. So I'm super excited. And one of the cool things that we did get was we got a whole bunch of really excited and keen people who wanted to do cool and innovative things. And now we gave them a place to do that. And so one of the first things that we did was really launch out Virtual MD and really expanding that ability for people to have a virtual consult with a physician that's part of our team. So you could call 811, and I'll give an example. We had a thank you letter from a mom. She had 4 kids playing at the farm. She's like, I think the little one has frostbite. I don't want to drive to Red Deer. It's a 3-hour drive from where I live. I don't want to drive to Red Deer. Um, Called 811 and said, what can I do to treat frostbite at home? And the triage nurse said, why don't you have a doctor look at it? And so they did virtual MD, treated at home, everyone's good to go. Record is in Connect Care so that if there's any need to go to Emerge for follow-up, it's all there. So virtual MD has been huge, and having, over 120,000 Albertans be able to use that, or at least visits, is really great. Finding a provider. So if you're looking for a family provider, so nurse practitioner or family medicine specialist, you can actually go to Alberta Find a Provider, and you can click on a button and you can look and see who's available. And if no one's available, you can click on Help Me Find a Clinic, and our team and PCN team will help you with A, what you kind of need urgently, and B, figure out how we can get you a care provider. Then obviously screening is so important. HPV primary testing screening is coming out, mobile breast cancer screening, APL, so Alberta, oh, it should say Precision. Alberta Precision Labs have moved over to PCA, which is awesome because they're great partners in delivering kind of that community care. They still do all the fancy, snazzy work. So under the governance structure, there's still that oversight to make sure that they do their cool pathology and fancy things I don't understand. But this is really nice for us as we provide kind of stable community care. And then that staff engagement piece is really important to us. We had a lot of people who came over excited to do cool things, but it's still scary and new. For lots of people, Alberta Health Services has been their employer and home for years, and to be able to be kind of like forcefully uprooted and moved was really hard. So we did a lot of work listening to what people wanted to do, things they thought were important, and then developing those mission, vision, and values. So I kind of talked about how much I love 811, but this was sort of a big thing for us to be able to do in the first couple of years or first year. So Um, Getting all those patients seen, being able to do the expansion is coming for virtual MD to be able to do pediatric care and also diagnostic imaging and 72-hour follow-up is stuff that's coming on the horizon. Um, 811 in Calgary and in Grand Prairie and the Indigenous Virtual Clinic, you can actually be triaged from 811 into if you need an in-person visit for Calgary PCNs, they can actually just book you in. So that's amazing to be able to do that and not having to go to a hospital and also have a booked in time to go see someone for that non-urgent but important medical care or urgent but non-high acuity medical care. And then we do run a 911, 811 shared response line. We do a whole bunch of other lines that I didn't know about. When we have measles or other communicable diseases things, so there was a Saskatoon farm E. coli outbreak, and they followed up. They did the lab requisitions for people. They do a ton of support for the rest of the system. They kind of quietly do that other people don't know about. And I think it's really wonderful that they're part of primary care and integrated with us. The Find a Provider leads us to have a demand registry, which is kind of a new thing. We don't have data. So for data people like me, I need you to relax. We don't know yet. But the idea is that we'll end up understanding how many Albertans are currently waiting and want to find a primary care provider. So there's various methods for the data people that we can use to measure attachment. So we can use based on the system like CPAR, CII. We can do it based on a method I hate called the four-cut method. There's a variety of kind of different ways. Amy and her team have worked with Primary Care Alberta to kind of look at some better methodology. That captures people who don't have a longitudinal primary care provider. Weirdly, some people don't want one, right? And they tend to be sort of classically, although we're digging into it more, like younger males who don't think they need a doctor. And we hear that anecdotally and from the evidence as well. But we know there are people who are looking for a family doctor or a nurse practitioner and can't find one. And so this lets us understand kind of who they are, where they are, so that we can go operationally and help do some stabilization, but also for long-term planning, where are communities that are struggling? So we launched this April. We've had 74. So in that first couple of weeks, we had 74 people who called looking for a provider. 50 of them were able to find a provider. 23 are on the wait list. And then of those kind of 23, 10 of them said, I will take virtual, I'm going to call it midterm care from TELUS, where they will follow you for test results, and follow up for a series of weeks or until you can find a primary care provider. So this is really exciting. And then long term, we're basically hoping to have a proper demand registry to understand these are how many people are attached and this is how many people are actually looking so that we can have a better understanding of that population. So again, I talked all about HealthLink. One of the things you may not know is we have the Indigenous support line, and that is a huge thing. And they provide not only navigation, but they end up providing a lot of cultural support and other things for people who've experienced a negative interaction with the health system, usually as a function of sort of culturally inappropriate care. And then the only other one is the low-dose CT and lung cancer, which we're going to continue to expand, but that'll kind of be a next year prize. So, as I mentioned, the Indigenous support line, if anyone actually cares, you can call 811. There's also the long number. And they really do provide a wonderful support. We have gone and talked to Métis Nation of Alberta, Métis Settlement, and then several of the nations, including the two Indigenous clinics that we run, and said, like, if anyone has a negative experience, if people don't like it, I need you to tell us right away. But everyone so far has found it really helpful, and we've actually had a few of our caseworkers follow people all the way through as they've had to navigate things like court systems. And so this is really wonderful kind of integrated care. The Find a Provider I told you about, this is what the buttons look like if you need to click it. It's pretty slick and I'm pretty excited about it. Told you about the screening van, but this is what it looks like. It goes around to rural communities. So there's the map. It runs around 300 and plus days a year. We have two mobile screening units. They are definitely focused, obviously, on rural and remote. And one of the things we're looking at partnering on is there a need for some of our communities in the city to do something smaller for some of our more vulnerable Albertans that might still need screening and testing, but just won't make it into our typical kind of radiology diagnostic imaging clinics. It would be good if I could click to the next slide. Ah, there you go. So this will be the next year prize, but this year is the sneak peek is that we are really starting to look at how our lung cancer screening pilot did so that we can roll this out into a full program in perpetuity. I think the really exciting thing about this is how many people were diagnosed at an early stage and just how much better that is for patient experience and how important it is that we get these high risk people being treated. And so ensuring that we can screen those at highest risk, that we can scale to a province-wide program. And part of doing that would be having a lung cancer low dose CT scanner in Calgary and Edmonton that we can utilize, but also mobile. We're piloting a mobile program with ASOS and Praxis to see how that works and learn about those kinks, and then actually develop a proper lung cancer screening guideline approach. I would like to give a huge shout out to the U of C who continues to allow us to have access to their CT scanner. We pay for it, don't worry, but that we're able to use to kind of move things forward until we can get a fully operational program. So that's kind of the screening, a little bit about the primary care. I think the public health clinics are really interesting. There's 153, which is pretty much every community has one, and they provide these core services you can see in that circle. Things like making sure that we have still a focus on reducing our sexually transmitted infections, but also a good understanding of sexual health, immunization, prenatal health, oral health, and then the postpartum and baby years. It's really across the lifespan. One of the things that we have done and one of the things we will be doing is really working on expanding immunization rates. So they're low. COVID didn't do anything to help that in terms of access and a whole bunch of other things. Population growth is huge. And so one of the very, very tangible things we're doing right now is actually just in expanding the learning links so that we can have more people immunized and partnering with groups like the Children's Hospital and potentially the Stollery to immunize people when they're coming in as inpatients, and then really making sure we have local strategies to meet people where they're at, and really leveraging the learning of where communities did a great job of getting people immunized during COVID, and that kind of culturally appropriate, safe care, understanding community leaders and working with them. We did do COVID vaccine this year, and that was hard, but we rolled it out as per government direction. I think the team did an amazing job under short notice, a lot of work. Next year, I think we'll probably see an evolution of that program. And then, of course, the never-ending gift that keeps on giving, measles. And so really coordinating that response and then also making sure that we're targeting groups for immunization and we're targeting second doses. Okay, so I think this is kind of like a redo of some of the things we said. I think one of the things that we want to flag is there's lots of babies being born. And so the number of, postpartum and even antenatal appointments are just growing every year. There's lots of babies, which is great. They're cute. But it definitely is really important that we make sure and we reach out to everyone for screening. The other thing is the Edmonton sexual response team moved to a better clinic space, and that being able to move co-located with police services has been a huge thing for us. And then home phototherapy for babies with bilirubin shenanigans. Okay, we're developing a chronic disease action plan. This one is rolling out. One of the things that's really important to us at Primary Care Alberta is that it's not just this strategy that's motherhood and apple pie that sits on a shelf, that's really tangible. And how do we work with our chronic disease care model that we have? And then how do we make sure this chronic disease care model is those six blocks up on the screen there with workforce and governance and all those things, evaluation. How do we make sure we kind of make that real? How do we make sure we coordinate everything across the chronic disease continuum from prevention, screening, management, all of that stuff? And how do we really anchor that in community care and making Albertans kind of informed, aware, and able to support their health. And there's lots of cool groups that are doing interesting things in this space. And so how do we test and scale and spread if it's appropriate? Year two, as I kind of mentioned, low dose CT scanning and a proper lung cancer screening, HPV primary screening across all ages. These are some really exciting things for cancer screening. When we look at an immunization, but when we look at year two, one of the big things that we want to do is really help transition primary care networks to be this strong support for primary care providers and patient health homes, and then really making sure that we can then provide that governance and funding that will allow them to provide more team-based care. So using more allied health professionals and other people to provide good team-based care, and then also being able to action referrals. And so a huge piece of that referral stuff is being able to work with specialists and helping people transition more smoothly, looking at the tools, the governance, et cetera, to make that happen. So these are some of the exciting things for year two. And so we look forward to hearing people's ideas and partnering with them as we build it out. So that's kind of it. The last thing I will say is that we at Primary Care kind of have four C's that is really important to us. One is that we are collaborative and we always work with people, that we're creative, that we're courageous to implement these ideas that people bring forward in a new system, and then that we are compassionate and kind, and that we remember that some things fail, everyone's doing their best, and a lot of things are happening in the system right now and in the world. So I sincerely appreciate the opportunity to come talk to you guys, and hopefully people have lots of questions, and I didn't bore you to sleep while you ate your sandwiches over lunch or whatever people eat over lunch. I don't know.
Yeah. Thanks very much, Kim. I'm very excited. Oh my goodness. It
Oh,
looks like Dean has added something to the chat that is going to take me a bit to read out. Please, I'm looking forward to
hmm.
this conversation as well. So hopefully some other folks
Yeah.
have some interesting things to bring forth. So given it was
I
the
read
first one,
Dean's comment. Do you want me to talk to him about it?
sure, you're
Dean,
go for it. So
I love
for
that
those of
Dean
you
announces who he is, like as if we don't know. But hi, Dean.
So for those of you that might not be able to see it, I'm just going to read it out just in case you aren't able to see the chat. Any high functioning public health system requires data. I would say the data access is reasonably good via Alberta Health. Thank you very much for that, Jean. However, access through acute care services or AHS data analytics has more barriers today than 5 years ago, and they seem to be operating under a different HIPAA framework. You now have labs under PCA. So where are we at among the various holders of data? So for
Mhm.
example, across the system on a common data access framework for this province. Because without data, we simply cannot have a functioning public or population health, primary care, acute care systems, so on. That is a zinger of a question, but thank you very much, Dean.
Oh, you guys, you're so nice. You have no idea the kinds of questions I get. This was actually, it's a really important question in terms of data access, and really actually Amy is, probably more aware than most, but the way that the system's set up is there's a health shared services that sits in the middle of it. And it is essentially the like old AHS infrastructure. Building that out to make sure that there is appropriate access for everyone is hugely important. I think, for us in the system, it's actually not hard. For people outside of the system, it's been extremely difficult. And I think there's kind of two things that I would like to maybe tell you guys we're thinking about. Well, one we're not thinking about is as primary care networks evolve, the idea is that they will, the way they want to craft the legislation, potentially allow them to be custodians, which would mean that primary care providers and data from EMRs could flow into an ecosystem or at least be shared in a much more reasonable way as it's like safe and appropriate with primary care provider input, etc. It allows us to do a lot more things if primary care networks, as they evolve, become custodians. So that's very exciting for us in primary care. It's a huge, 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 huge gap for us right now. And the other problem we have is the vendors for EMRs are impossible and they don't like to help us get data out. And so the government, this is where the government has to do their bit before I can do my operational bit. They are putting out standards is expected, interoperability standards, data standards, etc. And then our job at PCA is to help the primary care providers to actually work with the EMR vendors to get it out so that every doctor doesn't have to do that independently or nurse practitioner. So that's like a huge, huge piece for us. In terms of the ecosystem and access, my understanding is the framework is coming. This is one of those things that's actually like above my kind of work, but it is my understanding that's how that will go. One of the things that I think we have an opportunity to do as we can kind of understand the data access piece, get more primary care data into the system in a safe and appropriate way, well, then, like, we should actually figure out a way to work across all of our universities to set up some kind of primary care research consortium or something. Like, we should be able to be the powerhouse of research, real world evidence, living labs, all kinds of cool things, having a primary care agency that does that type of thing. So we are super excited about talking to kind of U of C, U of A, and others about like how can we make this happen instead of competing? Let's just work together and really kind of push the envelope. I have basically spent the last year trying to get my team happy and organized, but now is when we kind of get to do the cool stuff and we have to do it in partnership with everybody. It like I will have a crazy idea, but like to make it work, we actually need experts like Tyler and Dean and other people to say like this is how you should do it, this is the pitfalls, etc. I hope that kind of answered Dean. I think you got to be unmuted, so I'm hoping that works. Good. Dean gave a thumbs up, so I'll count that as a win.
Thanks. So just to highlight that, the video and audio have been open now. So if you're interested in asking a question or contributing to the discussion, please raise your hand. In the absence of somebody doing that, I'm going to return back to the comments and read the next one out. We know that prevention is so important. This is from Patty Stark. Can you speak to plans for health promotion and encouraging adoption of healthy policy within local and provincial government?
Yeah. So this is such a cool area of innovation, really, for health promotion, right? And I've learned so much from experts about ways that this works. So, the government will obviously kind of set some healthy policies or not. One of the things that I've really learned is some of that local uh, integrated health neighborhood that kind of local approach to doing things. We've also heard some really innovative ideas for how we can do things like, for example, we have an MOU with Obesity Canada, and I've learned more than I ever knew about obesity prevention and working with kids and how there are new ways and new kind of evidence for health promotion that you can adopt sort of at our operational level, but also locally to kind of encourage things. And so this is 100% not my area of expertise, but what I have learned is like really interesting. The team is starting to work on this. We are also working with schools to try and figure out how we can work with them, because you're at school for quite a long period of time during the day, and how can we kind of put in some of those early behaviors and things. And when I was working in Nova Scotia, I saw this thing with the Mi'kmaq communities where they actually had kids. They had a huge problem with not necessarily obesity, but just lack of exercise. And they did this gamification for kids on their phone, which seems counterintuitive, about like when you play basketball and schools competed with each other and then you won because you played more hours of basketball or did these things or rode your bike. But they put in the enablers in the community so that kids could do it. Like if you don't have a bike, you can't ride your bike. And if you don't have a basketball, you can't play basketball. But they kind of set that up at the same time as they made it a game, and it was like very successful. So those are some of the kind of neat things we're looking at where they have evidence to kind of try out here and see what they might work. I hope that kind of answered it. Someone who's a health promotion expert, we're happy to hear from you. My team is full of them and they tell me all kinds of things. Like I just discovered I have to eat 30 grams of protein a meal and not in a whole day. It's disgusting, Amy. I eat just cottage cheese and sadness. So like it's really good, all the neat things to learn, and that's where the digital front door helps too, is giving people actually the right information that's like that they should be getting as opposed to something that could be maybe not the best intent either by accident or on purpose on the internet. I
Yeah,
hope that
thanks,
works.
Kim. Anybody interested in raising their hands? Okay, I'm just throwing it out there. I'll return to the comments. This is from Eddie Felix. In a context where important public health functions sit across different agencies, so this is also a zinger of a question, Eddie. What mechanisms are in place to ensure system integration, avoid silos, and maintain a unified population health strategy?
It's a great question. And it's probably like a variation of the number one question we get is like, how do you make sure there aren't silos? And, there's all the governance stuff I can talk about. There's like an integration council and there's all these things, but I think I'll just go very kind of practically. When we talk about, core public health functions like mental health and addiction support up in that like upstream promotion, low acuity mental health and support, we know that primary care and public health play like a foundational role in that. And so we work with Recovery Alberta and mental health addictions to say, like, this is what we're doing. And then when someone needs more acute care, right, they have a higher acuity mental health issue or, mental health and addictions, then how do we make sure there's this gentle, safe handoff, right? I think one of the things that is existed in the system even before is there's no good handoff system, right? It's kind of like you get referred to your specialist or whatever, and then you just wait. And so how do we make sure that Albertans kind of like know where they are, know where they're supposed to be going, and that there's someone there to support them with those things? The concept of the integrated health neighborhood, um, which sits in our kind of public health, primary care, social services, et cetera. And that's one of the things we've sort of been anchoring it on.
Thanks. And I'll also just note that Lisa Allen Scott has put a
Oh,
link to Healthier Together, Building Healthy Alberta Communities Together in the chat for anybody that's interested in a little bit more information about program working with community, schools, workplaces, local health services. So thank you
okay. So
very
that's the
much.
smarter people than me. And I should have just let Lisa answer after. She'll be like, nice try, but.
Well, it's there for anybody who would like some follow-up. All right. So the next one. Also, I might add another zinger. As an epidemiologist, will you please enlighten the reasons for measles outbreak, although the several vaccination programs are ongoing?
Oh, I think these are just facts, so I don't think I'm going to get fired yet, but we'll let you know. Um, there's, I think, a couple of like factors that are kind of at play, and obviously there will be lots of kind of research and stuff that comes out about this. So I had the opportunity to work with one of the original measles outbreaks back in the early 2000s, dating myself in southern Alberta. One of the reasons that that measles outbreak was really kind of held at the same time as Fraser Health in BC had a massive measles outbreak was communication and trust between the population that doesn't vaccinate and public health. And actually, we're really blessed because Vivian is the chief medical officer, and she was the medical officer there at the time. So, like, when an outbreak happens, like by the time that we're at that point, and when it gets to be bigger and bigger, that kind of communication, trust, etc., is a huge piece of it. We were very lucky in public health at the time because the community told us someone flew back from the Netherlands and they were exposed to measles and now they're showing symptoms. That's amazing. We were able to contain that at like 40 some cases. In this particular environment that we live in, we have declining vaccination rates. A lot of them because people don't actually know they need to get 2 doses, they forget, they get busy, etc. It's hard for them. My gosh, one of my kids was off schedule because, and I only have two, and it was my job. So like we need to make it easier for kind of people to know and be aware. We have massive pockets of non-immunizers in the province that we don't and didn't have a trusting relationship for. And then I think, there was a whole misnomer that measles isn't really serious, that we got German and red measles when we were little, and people have kind of forgotten. And I think, unfortunately, um, what we know from some of our pregnancy issues and fetal demise and stuff like that is measles is super duper serious and super duper bad. I think all of that can serve as a really good opportunity for us going forward. And that's why I'm so excited that immunization is going to be one of our highlights for the next year. who's not getting vaccinated, why aren't they getting vaccinated, and how can we help them? I was at a cool clinic in Calgary where they have like a low sensory approach for neurodivergent kids that get referred from like the children's hospital and stuff for how they get those kids to be vaccinated. Because frankly, for their parents, it's too hard and not worth it. And they offer a very bespoke program for people with kids that suffer from severe neurodivergence issues. And so every kind of different, unique way that we can get people and use the evidence and the data to inform it is going to be helpful. But I think low vaccine rates, low trust, I mean, it's kind of like the perfect mix for a measles outbreak. And now it's just trying to kind of hopefully let it burn itself out, which we know mathematically happens, and then get everybody vaccinated before the next uptick. That was
Thanks, Kim.
probably maybe too long-winded, Amy. This is what
No,
happens when I know
no,
something.
never, never. And before I see Mike Law has his hand up, and before I turn it to him, I'll just also point out somebody else shared a link in the chat to promoting health. Another source of information there. So F. Bandali, for those of you that might want to check that out. All right, so hand up, go ahead.
Um, Thanks, Amy. Kim, we're academics. There's no such thing as long-winded. We practice the fine art of it every day. My question for you, I've been watching a lot of hockey lately. As you do when the playoffs roll around. And aside from being upset about the fact that the Montreal Canadiens, who my father cheered for, and I hated my entire life, are still in the playoffs, I've been sort of irritated by the number of ads I've seen for things like Felix and Maple and whatnot. And I'm interested in how you think about the care that folks are no doubt getting, the prescriptions they're getting, and whatnot from out of province providers, probably, who this stuff isn't going to show up in Connect Care. It's not going to show up in places where we can see it or where their primary care um, docs can see it. And kind of, so how are you thinking about this? And is it something that occupies your mind, or and if so, how?
I mean, what occupies my mind is that you're against the Habs, and I'm deeply concerned about this. Have you seen how
I'm sorry, I
adorable
grew up
that
outside of
team is?
Toronto. I have to cheer for the Maple Leafs. It's like bred
Oh
in
my
me.
God.
I know it's disgusting. I hate it, but
I
it's what
actually
I'm
think it's
stuck
a hate
with.
crime to let your children cheer for someone who is. And after they sent
They
Mitch
grew up.
Marner away, I was like, you guys deserve everything you get. So that long-winded piece aside, I think interestingly, I thought you were going to go with gambling because actually that's what I noticed on the hockey thing is like, are we making gambling addicts? This is terrible. But that piece aside, thanks for not asking about gambling. There's a whole issue with people seeking out of province, not just prescriptions, but now with the idea that people will self-refer for things, some of the private clinics that people are getting stuff at. And this is really kind of going back to that piece about making sure people have the right information and that there's trust in the system. And so I talk a lot to family medicine, like to family docs about this kind of thing. Unfortunately, if it's not in net care, that kind of is bad for an emergency. But if the family doc doesn't know that they're taking some kind of like natural supplement thing that they bought on the internet, whatever, that might be interfering with their drug and more important, their pharmacist, that's kind of problematic. And we've talked about it a bit as we roll out sort of team-based care. And how do we make sure that we build at least one trusting member of the team to kind of work with people who might either use like non-evidence informed medicine or buy stuff off the internet that they've kind of seen and think are important. I would love for people to teach us how we can build better trust because one of the things that we struggle with is a lack of trust in the system, but a lack of time on the hands of providers. And we know from the data that if your provider can spend some time, look at you, help you understand things, you do way better. But like, how do we make that time? And who's the member on the team that has enough time to be able to sit with a person so they feel safe to kind of disclose that? More to Dean's kind of piece, it would be amazing if we were to be able to share data across the country or anywhere else, but that might be a little bit of a bridge too far for us in primary care. I hope that kind of helps. That was a good question, though. And I'd love it if someone has a really spicy, good answer for it. I am more worried about self-referring and people ending up like getting like full body scans and then not understanding the implication of what gets found on that MRI that may or may not be important.
I worry a lot about like the sort of implicit gift relationship that's involved here because the folks are going to these clinics and paying money.
Oh
They're
yeah.
gonna end up with a prescription, and I worry a lot about like what the quality of that prescribing is going to be like. You probably guessed what I think is going to be the case, but that access is there,
Yeah.
and so self referral is probably going to equal self prescribing for a lot of
Yeah.
things.
Yeah. And it's okay, not it's okay. If it's a prescription that's done by a pharmacist in Alberta, you're good to go. It's in Netcare. If it's done by one of those private holistic clinics, then you start to run into where the government will have to set policy and direction about that kind of stuff. Okay. Amy, I'm glad my team is answering the questions in
Yeah,
the
it's
chat.
great. Well, it's
Right? I'm
great.
like,
There's
I don't know why
links
I'm
and
talking.
there's like tons of things for people to explore. It's very adventuresome. And I just wanted to also note that I received a private note to suggest that in addition to cottage cheese and sadness, you might want to add fiber buds in there to make it
Oh
extra
my
sad.
God.
So
I know.
just a
That's
thought.
the other part. I'm
I
supposed to
know.
be eating more fiber. Like, I
This is
don't
the
know
thing.
how to live like this.
No,
Yes.
you can't.
You need a
It's a loose.
dietitian.
Yeah,
It's a
I
lose. I
it
also
is.
think that at a follow-up seminar, Mike will need an intervention if he continues to cheer for what is got to be the worst team on the entire planet. And I'm not talking about the Canucks. I mean, like long-standing Leafs fans need therapy and support. And so an intervention may be required.
Yeah, speaking of sadness. Hmm. Yeah.
Okay, I see there's, I think, at least
Yes.
one more reasonable
Yes,
question.
there are at least two. So I'll read out the one that's next in line. With the mobile traveling testing, I see an opportunity for those who build such machines and or units to be multifunctional. So for
Yeah.
example, mammograms and lung screening, ideally one machine, many options. Oh, that reminds me of Star Trek. Not sure if those companies are looking at such machines or tools, and that's from Lindsay McClarty.
Yeah. So with them, kind of sort of no, but also wrap around stuff. So some things can be in a multimodal machine, and some of the new technology for being able to bring things in like to smaller communities. I will tell you, I've learned a lot about CT scanners over the past few years. They're not for the faint of heart to move around. They can't be jiggled. Mammogram machines also can't be jiggled. Ours got jiggled and had to get recalibrated. But CT scanners are super tricky and they're very heavy. So they can't really go kind of together, although I love the idea. But one of the things the team is really talking about is if the mobile mammogram machine shows up, why are we not also catching you for cervical cancer screening at the same time and fit testing and all of the tests? Like, lucky for you, not only are we going to smush your body parts, we are also going to collect your poo and swab you. I think that there's going to be a lot of uptake for just one shop hell, and then after you can go eat your cottage cheese. But yes, that is a huge piece we're doing, Lindsay, in all seriousness, is trying to look at how we kind of go out with as many tools and services at once. It may not be in terms of the technology because they're also very sensitive to how they move and stuff. If someone knows of any that are kind of being built together, but like low-dose CT scanning is built by, Siemens, GE, and other kind of big things, and mammogram machines are a little bit less sexy or expensive, maybe is the better word. And not just cancer screening, also like pulmonary function tests and blah, blah, blah. And I think Sachin has got in there about like, oh no, just privately funded care. Okay. Okay.
Well, and that's what put me in mind of Star Trek. The little, I don't know if you've seen it, like the little thing that you hover over a person and it tells you all the things that are going on, all the screenings for everything.
Your level of nerdiness
I know. I
every
can't
week.
help
Like I just
myself.
didn't
It's brutal.
tell. Yeah,
I
I
know.
love this.
Yeah. And I really, it's an important contributor to the conversation. All right. So next, this is from Bree. Tibbetts. Public health initiatives often take a long time to show their return on investment, which can often deter decision makers that want quick wins. How do we entice investment into the important public health initiatives that are needed but may not have significant returns for many years to come?
It's an excellent question. First, I would like to start with any said, well, this sounds great and seems to make sense. Like who, like where is our data to support this? Where was the evaluation? And they were like, oh, we didn't do an evaluation. So like step one is being able to kind of have that. There are short, medium, and long-term benefits to public health things, right? And so even just having the measles outbreak was horrific, but it did serve as kind of like a really good example that tugs at your heartstrings along with the return on investment. Because the reality is that dollars and cents only gets you so far, but a really good story sticks in your heart. And so one of the things that primary care is really kind of anchoring on when they're trying to, I would say, like promote things to the government is what is the return on investment data, short, medium, or long term? How does it help Albertans experience the system, and how does it help providers experience the system? And then when you kind of have those three, what's a story we can tell that will really kind of sit with people that they'll remember so that then they want to continue to promote it? And actually, we did not too badly with going to Treasury Board, actually showing some of these dollars and cents. And it was actually Lee Green who had information available. But this is part of that piece I said about more data, more evidence, more real world assessment of things that we are doing. Because even having an attached, we know when we look at attached and unattached patients, their ER utilization is less, right? If they're attached. Like we know that moms who get screened for postpartum depression in our well baby clinics, do better than moms that don't get screened, right? And so those are like very short and tangible, not diminishing the longer term health promotion stuff, but we can make our KPIs, markers, and indicators not necessarily be like long term. It could just be number of kids that have a healthy weight and are able to run around the playground as their KPI, right? It doesn't have to be years later how many people got diabetes, sort of thing. But I totally agree, and we've been pushing it a lot.
Yeah, it's an ongoing challenge for sure. So we've got a few more. The next one is from Kathy Eastwood, who's asked, online healthcare private access needs to be addressed by increasing recruitment and the availability of primary care physicians or NPs. What is the plan for recruiting more primary care doctors or nurse practitioners?
Excellent question. And this is the craziest thing. So I actually didn't believe it, but someone else can fact check me again. I was surprised. Calgary has enough family medicine specialists right now. And it's actually gone so well that some of our nurse practitioners practicing in like the donut communities are losing their panel patients because people are going back to family docs. And so what we have is an interesting spot where we have one community that has robust family medicine specialists and other primary care providers. And then we have absolute deserts. So it's a multifaceted approach. And I would say the biggest issues happen in rural Alberta. Um, we work with, and this is that collaboration piece, like the Rural Physician Action Plan and stuff. One of the things that we're going to look at a little differently, and obviously welcome everybody to kind of participate and offer some insight if they have any, is what is the root cause analysis of why a community can't maintain and attract physicians, right? Sometimes it is because the community is really remote. So I love high level, but it is a trek. And every time I go up there, I think, man, this is a trek. And that bear is cute. And also, this is too far. So finding the right people in the world, city, province, country that would love to live that kind of remote lifestyle is really hard. Making sure they have the right wraparound supports, that they're not having to run a business, that there's team-based care, that their primary care network can support them. There's a whole bunch of things that we can kind of do operationally. There is a government high-level strategy that talks about this, but we are much more local operationally delivering things. But we are working on sort of a root cause analysis that we can work with municipalities on about why can't I get a doctor, or why do my doctors keep leaving, that we're going to work on collaboratively with the government and Alberta Health Services. So I hope that helped. And online for short-term episodic care is like great. Like virtual MD is amazing if you've got frostbite and you don't want to drive in at like 7 at night. Long-term online care is a little bit tricky, and the only one we kind of work with is the Indigenous virtual clinic that exists, really to provide that sort of Indigenous specific care in rural and remote places where we can't seem to get even mobile support to them yet.
Awesome. Thanks. So
Yeah.
I received a very specific question about the women's health program
Mhm.
through a private message. Pardon me.
Okay.
Pardon me. This listener is interested to know if the women's health program includes looking at strategies related to endometriosis or fibroids that might lead to heavy bleeding or these other things.
Mhm.
And if it doesn't, could it be? And so that's the question.
That's a great question. So, women's health is a little bit of an issue of mine right now in that I'm entering my, what do we call it, like the elder years. And I realize I have to do all these things as I get older and fall apart. But women's health kind of goes across the continuum, similar to mental health, right? And what I have realized is that we don't have a very good coordinated approach. And women's health kind of touches on lots of things. So there is the women's health group that sits in Acute Care Alberta that people might have known as like formerly a PIN and formerly part of an SCN. But they are really focused on more high acuity stuff. We are trying to work specifically with the Calgary Health Foundation, who has a keen interest in women's health, and our primary care providers on what can we kind of do in the community for people who struggle. Endometriosis is a huge one because the wait time and the referral time to get specialty care is horrifically long. And how can we kind of bring that down? We also know that for most of our gynecological issues, the wait times are significantly longer than for sort of the urology male counterpart. Not that I'm trying to make it that issue, but it's long. And so we are working with them to figure things out. One of the first thing that we did is like launch the menopause pathway and trying to help people understand how to navigate it. One of the issues we have when we talk to our delightful primary care providers, a lot of them is can't know everything about everything. And as we get more and more information about things, it is hard for them to be the expert at everything. And so as we build out team-based care and primary care networks, what is that kind of perimenopausal, menopausal pathway? And then for our friends who struggle with endometriosis, how do we get them into a gynecologist or a care pathway as fast as possible so they're not just sitting there in pain waiting?
Thanks, Kim. So I've actually got the two questions that I have left that I can see. Although I'll note now that Tara,
Yes.
apologies, Tara, I don't know how to pronounce your last name, Seibert. I know it's a terrible
Yes,
thing
we
for
are
me.
going to work with H2A for
Aha.
sure. They do the
Okay.
panel, they do the panel
Sorry.
reporting right
There
now.
you go. I was just
They
going to
do.
point out to direct everybody to what's in there that Tara had posted. So thanks very much for doing that. So there's
Sure.
a couple of questions left, and they're quite sort of less specific than the one that we just
Okay.
received. So one of them is from Les Hagan. Hi, Les. Les is curious about whether PCA has increased funding or resources for chronic disease prevention.
So, not really. I'll be honest. We haven't even got a full year of funding yet. We will. What we need to figure out is where and how and what makes sense. We don't have a lot of money to fund things. We get funded a lot of our specific programs through MAPS. One of the things, though, about chronic disease that's going to be really exciting is freeing up kind of what I would call aligned but currently misaligned services that public health and primary care deliver, and kind of like how do we use the bulk of that to deliver more. We absolutely are going to need to fund more chronic disease prevention kind of stuff. Part of that chronic disease prevention strategy, prevention, screening, and management strategy piece is then going to allow us to go to the government and say like, hey, this is really important to us. And Sachin made a comment above about privately funded care. And so the sleep medicine ones are really interesting. And when people privately pay and it's privately delivered, that's harder. When it's publicly funded but privately delivered, that's easier. And so, Sachin, I'm happy to have like a conversation with you offline about it because I have a whole bunch of things I need to talk about sleep apnea, not for me personally, but like that we should chat about separately.
Well, that was a perfect tie-in because I think that was the last question that I see here, and that was an extension of Sachin's comment around the privately funded care, and returning it full circle to my love, of course, around data. Does PCA have a role in supporting access to data that lives in silos?
Um, yeah, we have to figure out the data silos separately. So we have to kind of work on how we're going to pull in things. And then, like I said, there's that piece about privately provided, publicly funded, easier, privately paid for, and privately privately paid for, privately delivered is harder. But I don't know if the government has thought about this as they kind of roll out some of their things with self-referrals, et cetera, et cetera. So we'll like to be determined.
Thanks. And I do, it seems I scanned it again and I'm sorry, it seems like it was Craig. So just
I
to
know,
read it
I
out, because
loved
it's very
it.
funny. This is actually Craig Butler under Sabrina
Hmm.
Plitt's login. I stole Sabrina's login code. My question about calcium score, more specifically, was have you considered pairing coronary calcium scoring with cancer screening? So we're
Yeah. I love it when doctors ask me a question where I'm just going to smile. Craig, what I would be happy to talk about is we are starting to talk about more holistic screening. So cardiac, kidney, there's someone else who came and talked to us, and in addition to cancer, right? So you kind of like you need to be screened for all kinds of things when you turn 40. So my magical world is you like open up your app and it says, Happy birthday, Amy, you're 40. And here's all the lab tests we've already ordered for you. You're going to get your A1C, your cholesterol, all these kinds of things, any kind of other thing that might be necessary. Answer a couple of questions to see if your kidneys are at risk, whatever it is, all of it kind of integrated the way that we build on the foundation of cancer. I'm going to tell you, Craig, I'm not secretly a cardiologist, but I'm super happy to talk about like how coronary calcium data would help with lung cancer or any of that stuff as we roll out the lung cancer things. But I can truly tell you, you've gone way beyond my expertise area. And also say hi to Sabrina for me. I'm so glad you stole her login. Oh, you're on mute, Amy. I love this for you so much.
classic. Darn it. Ah. So with that, what I was about to say was that we're a minute out from the hour. So I don't see any other questions streaming in at the last minute. Thank you very much, Kim, for taking the time to share your experience and knowledge with us and all the the interesting conversation and
Rambling.
contributions today. So thanks very much again, and thank you all. Please pay attention to this series. There's more folks to come in future that will be sharing their information as well. So all the best, everybody. Have a great Tuesday.
Thanks, Amy. Thank
Thanks.
you, everyone.